right, so we are basically online, so we can start right about now.
Okay,
Okay,
but this will not
ladies
be
and gentlemen,
recorded.
welcome back.
This is not be recorded at YouTube,
No,
is
no,
it?
no, no, we are not going to record this. All right,
Good.
so ladies and gentlemen, welcome back to our international ground. I'm very glad today because I have one of the mentor during my coronavirus disease period, Professor Tom Hummell. Good morning, Professor Hummell.
Morning.
So good morning, good afternoon, good evening. It depends on where you're connected from. I've been lucky to have some connection with Professor Thomas Hummel since my early March period. He was helping me mentally and actually in kind of form of physically. He was helping me to providing me information on what to do and what not to do when I suddenly became completely with my anosmia and my ageusia. So for those who don't know, this is one of the main symptoms that is frustrating all the people that got affected from coronavirus and from SARS-CoV-2. But today I've requested from a professor to have a talk regarding some smell disorders, diagnosis, and how to treat them. So if anyone is connected worldwide on our Zoom platform, do remember that all the questions should be typed inside of the Zoom application. Or for the others that are connected from Facebook, YouTube, Twitter, LinkedIn, you can type your question and I will manage it. But all of them will be replied at the end of his presentation. So, Professor, it's your time to share your presentation and your experience because for those who don't know, Professor Samasomo is one of the most important and well-known mentor in around the world. Thank you so much, and please join your presentation.
Oh, Puya, thank you very much for this very nice introduction, very flattering. So my task is here to talk about the sense of smell and about olfactory disorders, how to diagnose it, and possible causes of olfactory loss and how to treat it. So I'll give you like a brief overview in about 30, 40 minutes. So so that's about classification of olfactory disorders. I guess you're familiar with many of the things that I'm about to tell you now. So you have quantitative olfactory loss, that means anosmia, you have no sense of smell, you have hyperosmia, little olfactory function, you have hyperosmia, and this is like an increased olfactory sensitivity. Hyperosmia, probably it's difficult to see that. Actually, personally, I think I saw only one person with hyperosmia in my life. That was a person with epilepsy, and he could smell things from a distance. Typically, what you have here is that people who claim that they're hyperosmic, they are often not. They are annoyed by many different odors. So it's called multiple chemical sensitivities, or like another aspect of that would be, for instance, pregnancy, where women also, without being told, is that during the first trimester of pregnancy, they exhibit all kind of hypersensitivities towards odors. But if you do testing in them, then they actually appear to be hyperosmic. So they are, or normosmic at least, so they're not really hyperosmic. So it's difficult to see that in people hyperosmia. Still, it exists. Then what's also equally important are the qualitative olfactory loss. That's what Puya experiencing at the moment. So it's parosmia. So you have an odor distortion in the presence of an odor. So you smell something, and this doesn't smell like it used to smell, but it smells very different. So typically it's a uniform smell. People have like that everything smells the same. It can also be kind of also different shades of that gray. So you perceive, for instance, I present vanilla to you, and then you tell me, oh, this smells like chemical, unpleasant. And then I present cinnamon to you, and then you would say, oh, it smells also chemical, unpleasant, very similar to what the other odor is. So it can even be fecal, that everything smells like garbage or like rotten food or like feces. And this is then not nice. So these people, they are being depressed and they stop eating actually, because everything we eat is also smelling like this. This is parosmia, and then you have odor phantoms. Odor phantoms, they are present in the absence of an odor. So these people have odor phantoms all the time, often, or for hours or for minutes. They come out of the blue, and they are there. These are called odor phantoms. Often you find odor phantoms after post-traumatic olfactory loss, so when people bump their heads and they have intracranial bleeding or damage to the olfactory bulb or to the orbitofrontal cortex, then they would develop often these odor phantoms. But they also can be there in sinonasal disease, for instance, but less frequent. So I need to click on further. So how do we explain parosmias? So one idea to explain is to look at the coding of olfactory receptors of odors inside the nasal cavity. So for instance, when you smell rose odor is activating not just one type of receptor in the nasal cavity, but activates a range of different odors. Let's say the R, the O, the S, and the E receptor. And they together produce a picture in your pattern in your olfactory bulb. So where it sort of reads rose. And then you smell orange, and orange activates O, R, A, N, G, and E receptors inside the nasal cavity, and the pattern that emerges in the olfactory bulb and in your brain is orange. So this is how we envision that odors are being encoded. It's a pattern that is developing. When you have parosmia, then one of the ideas is that some of these receptors are present and others are not. For instance, you smell rose, but the pattern is incomplete. And this is why you smell rus, or something not complete. So it's not the rose odor, but something funny and strange and is sort of evaluated as unpleasant. Or you do not smell orange, but rum. So this is how one idea is about the generation of these parosmic impressions. What are the causes of olfactory loss? It's like typically it's aging. Age is the one and foremost important cause of olfactory loss. So the older that we get, the less the olfactory function is. The second thing is, so for instance, if you ask people older than 80 years, like 1/3 or 1/2 of them, they have no sense of smell or very little of it. So it's really prevalent. When apart from that, it's the sinonasal disorders or inflammatory disorders. About 2/3 of the causes of olfactory loss, they are sinonasal. Then you have post-infectious olfactory loss, so it should be post-infectious, not post-viral. Then we have head trauma, we have iatrogenic causes, we have toxicity, we have congenital olfactory loss, we have idiopathic olfactory loss. Apart from that, there are neurological causes like Parkinson's disease or Alzheimer's disease that also come along with olfactory loss. And actually, olfactory loss is a very early sign of Parkinson's disease that is sort of preceding the motor symptoms in Parkinson's disease by up to 10 years, maybe even longer. So, yeah. How do we measure olfactory function? You can ask your patient, of course, it's very important. But when you ask healthy subjects, for instance, here that's shown in the result is shown in this study. Here, people have been asked about their olfactory function, and then it has been measured. And what you see there is that there's no correlation there. So what people tell you, at least in this study, is not very coherent. So some people can be very wrong about their own sense of smell. This is also shown in this study. This study we did together with people in Taiwan, Brian Shu and colleagues. What did we do there? We looked for people with about 1,000 people in different age groups, 18 to 35 years of age, 36 to 55 years of age, and older than 55 years of age. And what we found here is that of those, we had the measured olfactory function showed us that in 4% of people with 18 to 35 years of age, they had an olfactory problem. In the middle age group, it was 17%, and the oldest group was 36%. So this is what you would expect. When you actually ask them about the olfactory function, it's very different. You get the same degree, the same percentage of ratings in all different age groups. So all different age groups would tell you that they're to the same percentage that they have a decreased olfactory function. So again, what does it tell you? If you want to know whether people have a functioning sense of smell, you want to measure it. you want to do some measurements about it. So skip these slides here. Certain ways to measure that would be the scratch and sniff test, the upset. It comes from the United States. You have these 4 booklets of they are in each booklet you have 10 different odors. You find the odors in the scratch pad and the bottom of the page. You scratch it, you sniff it, and then you select the odor identity from one of these 4 items. So the test is very nice. It has been tried and true. You can mail it to patients, although sometimes they worry what's happening at the place where people fill in these forms, because probably the entire family is sitting around these tests and they're filling it like together. You get like an average of the affective function of the family. But it's a very nice test. It has been very reliable. It has been adapted to different countries on the planet. Still, it comes from the North America, where certain odors are being used. For instance, wintergreen, and it's difficult. If I ask my patients in Germany, nobody would be familiar with the term wintergreen. They just don't know this. But it's also not inexpensive. We did come up with a different solution to that with the sniff and sticks. So it's reusable, that test, or it comes in various versions. You can have screening tests with that, or an extended test with 32 items. It comes as an odor threshold form with odor discrimination. So it allows you to test more than just odor identification, which personally I feel is important. Why is it important to test not just, so for the sniff and sticks test, over than about 10,000 people have been tested with that, normal subjects that feeds into the database for that, into normative data. Why is it important to look also at odor thresholds? Because of this phenomenon here. For instance, because there may be a discrepancy between odor thresholds and suprathreshold affective function. Suprathreshold, it's what we call odor identification, odor discrimination. They tell you different things about the sense of smell. Odor threshold, as shown here, is when people get older. For example, what decreases first is odor thresholds. And this is then gradually followed by odor identification and odor discrimination. So first, and here the idea is that you lose function at the level of the olfactory epithelium. This is what's shown and reflected in odor thresholds to some degree at least. And later on, when odor thresholds are really, really bad, when you have almost no function in periphery, then this is followed by a decrease in odor identification and decrease in odor discrimination. So different olfactory tests, they show you different things. So that's why we feel it is important also to look at different olfactory functions. What else to be used for olfactory testing? We use retronasal function testing. There's a retronasal odor identification test. It's basically very simple. So we put like spices into the mouth of our subjects, and then people select they identify the flavor from a list of 4 different items, because the flavor approaches the olfactory epithelium from the back. Normally you have orthonasal function, you have retronasal olfactory function, and what we know is that, for instance, retronasal olfactory function flavor is more important to people than orthonasal function when it comes to quality of life issues. So there's a nice correlation between retronasal function scores and quality of life issues, that's shown here, which is not so good for orthonasal function. In trouble here, clicking on. Then we do EOG recordings or event-related potentials. These are EEG related and based signals that we extract from the EEG. We also can do recordings from the periphery of the olfactory epithelium. We place an electrode there under endoscopical guidance. We have these event-related potentials. Here you see a case of a patient who has no olfactory function, but still responds to trigeminal stimulation. So trigeminal function is okay, olfactory function is not. Then here you see the same thing in time frequency analysis. So it shows you a nice signal for trigeminal activation and little signal for olfactory activation. We also can look at the source of these signals, so we can track it back where it seems to come from. We also can do functional imaging in patients, but functional imaging, it's in experiments, so in experimental studies, it's very helpful, gives you a lot of insights into olfactory function, also on a group level in patients, but individually in patients, it's not very helpful. There is no study that really showed that fMRI in individual patients, not on a group level, in individual patients, that it would be helpful. So it's difficult to use, for instance, in medical legal cases. Then you have structure imaging, of course, of the brain, and this can tell you much about the sense of smell. Structure imaging that includes also imaging of the olfactory bulb. In this case, for instance, you see very flat olfactory bulbs. So you see also this structure here. So this person probably has an olfactory problem. Just by looking at the structural brain scans, following this schedule here, I can more or less tell whether people are hyposmic or normosmic. So structural brain scans are very helpful in the diagnosis, for instance, in post-traumatic olfactory loss. Another structure that is important is the olfactory bulb. And just looking at the olfactory bulb, it tells me some information about the prognosis of the disorder. What do you see here in this slide? So this slide is quite busy. What did we do there in this study? We had together with people in Brussels with Philippe Rombaud and Caroline Huyard and colleagues. What did we there? We invited people to the clinic. We did an MR measurement of the brain, and then we measured the volume of the olfactory bulb. And then we brought people back after a period of, I think it was 8 months or so. Sorry, it was a little bit longer. It was 14 months. And then we looked at the olfactory function again. And what we found here is, what you see there is, that's the plot of the initial total olfactory bulb volume plotted against the change in olfactory function. What you see there is, the larger the initial olfactory bulb volume was, the better the improvement of the patients. You see that here on this side, also in the bar graph. See, for instance, when the initial olfactory bulb volume was between approximately like 40 cubic millimeters, then the was between 61 and 80 cubic millimeters, then their chances for recovery were approximately 35%. If the initial olfactory bulb volume was between 80 and 100 cubic millimeters, then the chances for recovery were in the range of 60%. So the olfactory bulb tells you much about the prognosis of the patients. This is why we are interested in the olfactory bulb. It's also a nice thing to show you on a morphological level, give you some ideas about olfactory function. What can we do? So diagnostics of the olfactory loss is manifold. Most important is that you talk to your patient, of course, that you do psychophysical measurements. Very simple is to do odor identification tests. Important, what we think, is also to look at odor thresholds. In addition, you can do electrophysiological measurements, so you can do recordings peripherally from the olfactory epithelium. You also can do measurements directly from the EEG, from the cortex, or you can do structural and functional MRI. Structural MRI tells you, you can look specifically at the olfactory bulb, gives you much about prognosis of the patient. You can do functional imaging, that's experimentally interesting, but not in individual patients. So that's a range of different things that you can do, starting from the periphery up to the cortical level of the processing of the information. What can you do to help these people? I will not talk here about sinus-nasal disease, or I will also not talk about age-related olfactory loss. So what can you do in post-traumatic or post-viral olfactory loss, or post-infectious olfactory loss? Here, first you have to counsel the patient. And in a way, or not in a way, but this also refers to patients with corona-associated olfactory loss. Basically the same currently as we see it at the moment, same as post-infectious olfactory loss. So the chances for spontaneous recovery in people who have long-term olfactory loss, they relate to the remaining olfactory function. So how much olfactory function is left? The more olfactory function is left, the better the chances for recovery. Of course, the cause of olfactory loss is important. So when people have post-traumatic olfactory loss, then the chances are much lower than people in post-infectious affective loss. But one has to say, when people after head trauma, they still have a chance for recovery. And it's in the range of 30% over the years. That's what we see often, that patients come to us and they've seen other ENT colleagues and they told them, because they visit them with post-traumatic affective loss, they told them there's no way, your sense of smell will never recover. And this is not true. So in about 1/3 of these patients, the sense of smell will return to some degree. It will not, it rarely recovers fully, but you see recovery in some of these patients. Recovery is much more frequent in people with post-infectious affective loss. You see recovery rates in long-term affective loss in about 60% of this population, maybe even more. I'm not talking about short-term affective loss. I'm talking about long-term affective loss in relation to infections of the nasal cavities. The longer the affective loss had been lasting, the less likely affective loss is. But in our studies, when we look at people who had affective loss since 9 years after head trauma, for instance, there's still some recovery. So there's still the possibility of the affective system to regain function, to recover. Age is a major factor. The older people are, the less likely that affective function will come back. So, but there's also, the question would be, where's the limit? So at what age will there be no recovery? And the answer is, we don't know. Actually, only like, I think 5 weeks ago, I saw a patient with 75 years, and she recovered almost completely from that was post-infectious affective loss that she had for 1 year. So that was really amazing that this old woman, she showed almost excellent recovery of their sense of smell. It's a little bit exceptional, but even in people at this age, or an age of 75 years, you sometimes, not often, you see very good recovery. Sex seems to be important. So in women, we find more recovery than in men. It's also a little bit more complete. Parosmia is in post-infectious affective loss typically a good sign. So it seems to be correlated with recovery of the sense of smell, with regrowth of effector receptor neurons. So that's good for people with parosmias. It helps them to go through this parosmic phase because it shows activity. These people perceive odors, but their coding is sort of wrong. But the basic message here is that there is olfactive function. So you can perceive odors. And at some time, so sooner or later, it will turn back to normal. So the parosmias will, with a very high likelihood, go away and make way for normal olfactive function. So parosmias, what we see in our studies, people with parosmias tend to recover faster and more complete. Smoking is never a good thing. So when people smoke, then their chances for recovery are less high. But talking people out of smoking, as you know, is difficult. Only I think 3 weeks ago, to my surprise, I had a young patient, he said he quit smoking after I told him to quit smoking. I was in awe of this. So, but it happens. So don't give up, tell your patients they should quit smoking when they want to have their sense of smell recover. What else can you do? So a couple of things that probably do not work. So there is estrogens. They do not seem to have much of an effect in post-infectious affective loss, also in post-traumatic affective loss. Zinc does not seem to be helpful in post-infectious affective loss. There is one study from China showing that zinc seems to have an effect in post-traumatic affective loss. Very convincing study, but there are a couple of other studies showing that this is not so. So currently it's a little bit undecided. A couple of other drugs that have been tried with little effect, there's minocycline, sinopret, systemic vitamin A has no effect, pentoxifylline also little or no effect in post-viral, post-traumatic affective loss. What might work are corticosteroids. So there's some evidence that they're helpful in post-traumatic affective loss. In post-viral affective loss, it's maybe initially, but actually in long-term post-viral or post-infectious affective loss, there's no single study that would have shown that steroids would have been helpful. So acute state, or say in a fresh infection, yes, it may be effective, or like in post-traumatic affective loss, also steroids may be of effect. Of course, not when it has been longer lasting. But in longer term affective loss after trauma or infections, it's probably not very helpful. Caravarian may be helpful. The thing is that the drug is not available anymore, and alpha-lipoic acid could also be of help. But the study that I'm pointing at was not placebo-controlled. So that's the evidence for that is not very high. What might work is like sodium citrate buffer. There's a study from Greece that showed that about 97% of patients responding to local treatment to topical treatment with sodium citrate buffer. We did 2 studies on that, and together with Carl Philpott, another study, so 3 studies, and this was not successful. We blinded our studies, and sodium citrate buffer was not very effective, but it was effective in odor phantoms. So that was the only thing where we could see some effect. Acupuncture, there have been some studies showing also not very equivocal. So some studies showed an effect, others did not. Actually, this study in the same journal, actually, there was in the same year, there was this study that showed that the statistics of this predecessing study were kind of flawed. So that was not very good. So what might be helpful is vitamin A applied topically to the olfactory cleft in post-infectious olfactory loss. So our studies show, or controlled studies show, that there's significant effect there. How did we apply our system? How do we apply vitamin A in these patients? These are some ways to apply nasal drops. But what we can see here is in this study from Benninger, this review from Benninger from 2004, on top you see the various positions, how the drops are being applied. On the bottom, you see the distribution of the drops inside the nasal cavity, and what you see, even in this uncomfortable muffled position, you see that it only reaches the middle turbinate. It doesn't get up to the olfactory cleft. What's more effective there is the kaiteki position, when people lie on the side and they tilt their heads and they apply the drops to the nasal septum. So if they do it, that's before treatment, and this is after treatment. So if you apply it, or if you tilt your head, you lie on the side, you apply the drops from the top to the nasal septum, wait for half a minute, then the drops actually, they can reach the olfactory cleft. So, and this is a position that is halfway comfortable to the patients. So even adipose patients can do that. So if you want to refer to vitamin A nasal drops, then please use this position. What else can you do in olfactory loss? You can do olfactory training. We started that some 2008, some time ago. We used these 4 different odors: rose, lemon, eucalyptus, and cloves. We did that according to studies from German physiologists in 1916. That's a longer story behind it. Basically, the idea was to activate different areas of the olfactory space, so of 4 different dimensions of smell space. And this is what we had. It was rose, lemon, eucalyptus, and cloves. The instruction was to sniff those odors twice a day, in the morning and the evening, for a longer period of time. So in this case, we started with 6 months. So the advice was not that people should smell odors as often as they could, but actually they had a regimen. So you smell these odors twice a day, 30 seconds each odor. You do this regularly, and not the advice, smell as often as you can. That's probably, people do that. If you give that advice, patients do that for sometimes for 2 days, sometimes for 10 days, and then they give up. You know, they do it irregularly. You know, they don't do it regularly. The message here is do the smell training regularly, twice a day. If you advise patients to do it more often and with more different odors, again, the same thing. Patients do it for a certain period of time, but then it becomes too much. It becomes overwhelming, because think about yourself. How much time do you have every day? So your day is busy, you know, you start up in the morning. If you can free 4 minutes every day in the morning and 4 minutes in the evening, it's a lot. You know, it's just taking out 8 minutes of your busy day, you have to be really focused on that. If you ask people to take out more time, it becomes difficult. Not many patients will do this. What does this study here show? It's a multicentric study that we did in Germany involving like more than 140 patients in several different centers. That's the spontaneous trajectory of patients. The red symbols show you how people recover over a period of 14 months. So let's have a look at 8 months. So after 8 months, approximately 20% of the patients show recovery. What's happening when people do smell training? It's more than twice as many. So smell training seems to boost olfactory recovery. This is what we see. So it seems to amplify the natural recovery of these patients. You can improve the recovery rate, the success rates of that, if you change odors if you start changing those odors. That's a study from Turkey. That's the spontaneous recovery in this study. This is like the classical olfactory training after 12 weeks, 24 weeks, and 36 weeks. So it seems to plateau at some points. And this is when people do a change of the odors every 4 months. So this seems also to boost olfactory function. So it increases the success rate of olfactory function. So the various odors that we used here. So we started out the rose, and lemon, eucalyptus, and cloves. And then people switched to those 4 different odors. And in the end, they switched to another 4 odors like this green tea, bergamot, rosemary, and gardenia. They changed the odors. So does long-term olfactory training help? And the answer is probably yes. That's a study from Ioannis Konstantinidis in Greece in patients with post-traumatic olfactory loss. That's, you see here at the bottom, spontaneous recovery in these patients. This is where you see the trajectory of patients who trained for 16 weeks, so for 4 months. So they improved for 16 weeks, and then they stopped training. And what you see there is that they did not return to baseline, but they stayed at this level. I think that's also a very important message. And when people continue training, then they even improved further. So there was a significant additional increase in olfactory function. So to show you this here again. So what do we learn from these studies? It seems to be helpful when you do regular training, or when you adhere to the training, when you switch odors every 4 months, and when you do training for a period longer than half a year. Sorry. What does it do? What does olfactory training do? It helps you in terms of olfactory function tests. You become better on sniff and sticks tests. Also, your ratings of olfactory function improve, of course. We measured that also at the level of the olfactory epithelium. So we placed an electrode on the level of the olfactory epithelium, measured olfactory function. And what we found here was that patients exhibited, that was before the training, the number of responses, about half of our patients responded. And after the training, it was about 90% of the patients who showed some type of response. And so what does this mean? It means that olfactory training seems to increase the number of neurons responding at the level of the olfactory epithelium. So something is happening in the periphery of the nasal cavity when you do smell training. Something is also happening at the level of the olfactory bulb. These are standard deviations here. This is shown in healthy controls, but you see similar things also in patients with olfactory loss. So the olfactory bulb is growing. It also changes your brain structure. So there's numerous studies showing that if you do smell training, it increases connectivity of your brain. It changes actually the olfactory bulb volume, that's shown here in these various studies. And it also increases the structure in the volume in the hippocampus, and also in other areas related to olfactory function. So smell training works on various levels. So not just on a cognitive level that you pay more attention to odors, but also you see changes in the periphery of your nasal cavity, you see changes at the level of the olfactory bulb, and you see changes at the level of your brain. So that's shown here again. So you see more activation on the functional level, in people and patients who did smell training, and more connectivity also. What else can you do? Just some future here. You can try olfactory implants. They do not exist yet, but people are starting to think about it. There's even before anything had been done, there's already a patent on it. So it's kind of funny. So before anything has been published, it's already patented. There's an interest in that. There's also a basis for that. So if you stimulate the olfactory bulb electrically, then it can produce olfactory sensations. There was a recent study by Eric Holbrook, and it's basically, and colleagues, and it's basically the basis for the application of olfactory implants. What else can you do? You can think about transplantation of the olfactory epithelium. So you can harvest olfactory receptor neurons. You can grow them outside of the nasal cavity and can reimplant them. There was recently a very nice study by Sarah Kortenbach and Brad Goldstein and colleagues, and they showed in an animal model very nicely that this is possible. So before we can do similar things in humans, there's a long way to go, but it just shows you that there are also other possibilities out there. So with that, I'd like to finish. Thanks very much. And what did I tell you here? Like olfactory function, you should, when you talk to patients, you should also talk to your patient a lot. It's very important. Patients have to rate their olfactory function. They also, you should measure it. So physically, you should look at odor thresholds and odor identification at the same time. There are other ways also to look in a more objective way, in a less biased way at olfactory function, so on various levels. And you should do that. Just talking to the patient, getting ratings from patients, it's important, but it's not everything. It can be misleading to some degree. And you can treat it. So there is a chance for recovery. That's based on the plasticity of the sense of smell. The sense of smell can recover. So olfactory receptor neurons, they can regrow. You also have plasticity at the central nervous system in terms of olfactory function, and this can be stimulated. You have various ways to do that. You can use smell training, or you can use local topical vitamin A, you can use acupuncture, you could use alpha-lipoic acid. There are a couple of other things out there. You could use omega-3. So a couple of things are possible. So that's basically what I wanted to say. Thanks very much for listening.
So first of all, I would like to congratulate with you because of the brilliant presentation from the first part to the end. By meaning of this is that you cover all the fields that are essential for our listeners and viewers to understand, because our association is built not only from from colleagues and scientists but also from patients, and we need to put some advices for them also in either. So at the same time, I would like to have some questions before going to the questions from the audience. Many of them are, giving you some, compliments regarding the best lectures on olfactory function improvement since now. So I will also congratulate with you about this. There are some questions that I personally would like to address. For those who don't know, I'm an ENT surgeon, I'm a rhinologist, I've been busy around for surgery, and I always seen, and all the patients came up to me and say, well, doctor, I have some problems with my smells and my taste, and some of them were actually suffering from chronic rhinosinusitis with polyps. So for those patients who were actually, explain to them problems that could be managed, sometimes but sometimes not. It depends on surgery and topical administration of steroids and others. But for those suffering from viral or post-viral, post-infectious disease, where I was in a position in which I was not be able to give them an answer or suggestions. But since I've been, affected by this, and I complained this during my period in March, and I'm actually not aware to tell everyone that I'm suffering from parosmia, and I'm one of those people that's suffering from that bad taste and bad smells. it is sometimes retronasal, sometimes from the from my nostril it came out. Not all the time, could be triggered from some smells, or sometimes even from air. uh, I need to bring to those people some advices, but I want you to give them some advices, and some of them you already covered. You already said that sometimes when you have some parosmia, that means that your olfaction could be restored completely. Of course, we don't know so much about these viruses. I'm talking about coronaviruses, SARS-CoV-2. I've been affected in March. I was one of the first one that described my situation worldwide, but I was one of the one that said, well, after 1 month, I got some recovery. But now it's time to provide some information on how to get recovered faster, how can be possible to use steroids, because as you remember, we've been taught about the WHO, so don't use steroids, systemic steroids. But after 5 months, the debate come out and say, okay, use corticosteroids, but there's a time in when you have to use steroids. So the debate is this: do you think that steroids somehow at the initial part of of the disease, and I'm talking about coronavirus, do you think that those topical steroids in the first week could be beneficial, or you would say, well, we have to go further with some studies because we don't know too much?
Yeah, I think that's exactly what you're saying. So, I mean, you asked me this question because you assumed that they would be helpful, and I would subscribe to that. So, I also think that they could be helpful, but there's too little studies on that. There's very little. So I think this needs to be tried. It would be very interesting to see what effects it has. But this would require also like a controlled experiment, which is difficult to do. So
That's the question, is because, as you and all the people are aware, we in Italy were the first one, I mean the second or the third nation that got affected so bad in the period of March. The problem with us was always that we could not do autopsies in those patients because of legal issues. We were not be aware, we were aware about this, we had so many problems with this. But in the last reviews, in those few months, some articles, some papers came out with the neutral, the possibility that the virus could be neurotropic, and it could affect directly the olfactory bulb. So in that, do you think that these viruses could potentially restore, or could hide himself inside of the olfactory bulb? And in that case, what would happen if we use steroids?
yeah, that's an excellent question. I mean, it has been shown for other viruses that they hide there, like the Sendai virus, and it was in the rat, it was not in humans. But you could imagine that similar things are also happening in humans. That some viruses, I don't know about coronaviruses, where they sort of hibernate there and then produce damage at some later point. This is unclear. Um, but but there's no data currently on this. But I don't know what influence steroids could have on that hibernation or that long-lasting survival of coronaviruses in the brain. But you're certainly right that it looks like the olfactory system is like the highway for the coronavirus to the brain, at least to the olfactory bulb, and from there maybe to other areas in the brain. So we had one study where we showed that there's a neuritis associated with corona, in fact, with COVID-19, so that you find signs of inflammation along the olfactory nerves towards the olfactory bulb, and also, so it may well be that your coronavirus is spreading into the brain through that. But you ask very good questions, but there's also no answer to that right now, at least not to my knowledge.
I know. So I'm bringing my cheers from our colleagues all around the world. Some of those and Neurotrica, and others from Greece. Yanis Konstantinidis is bringing cheers right now. They're live, and uh, Let's start with the questions from the audience, if we will have some time. The first questions come from Dr. Prakash Munka from India, and he or she's asking how long it should be the olfactory training should be done. I think that the questions has been already been replied from one of those previous slides. But could you please advise to our people, to our colleagues, how long do you think should be maintained this olfactory training?
Basically, there's no limit. So, but what studies, and especially because you mentioned Jordanis, so Jordanis Konstantinidis in his study showed very nicely that if you do this for a year, then it's still helpful. So, the effect may be a little bit, the trajectory may be less steep, but it still can provide people with some help. It's still, you need to tell people that they should do it regularly. So, just sniffing a little bit here and there. I have to maintain it because, like, many people mistake that they go to their kitchen and sniff a few spices like once a week. This is not smell training. So smell training is something we have to be focused on odors, and this is yeah. So that, as it looks like, even if you do it for a longer period of time, it still can be helpful.
There another question from Diwa Kerbista. When should we order imaging MRI for factory loss?
That's a very good question. Personally, I would love to see MR images in every patient because I like to look at the olfactory bulb. At the same time, you see the nasal cavities, you see the olfactory clefts. So you can you have a much better informed diagnosis of the patient's olfactory loss. So that's what I would like to see MRI scans all the time. But it's a question of money, of course. And typically, where we clinically always see, or like most of the time we see MRI scans, I have to say, is in people with idiopathic olfactory loss. Then we want to see whether there's a tumor of some sort, whether some, I don't know what in the brain behind that olfactory loss. And if possible, we also see it in post-viral, and of course, like in post-traumatic olfactory loss also. So, but in post-viral olfactory loss, it's not mandatory, of course not. So you would never assume that there's a tumor behind it of any sort.
What would you check out when you're looking for an MRI? What are exactly those anatomical compounds or other structures that you're looking for when you have some patient with olfactory loss?
I specifically look at the olfactory cleft, whether it's open or not. It's often overlooked. So you look at the general nose, you look at the sinuses, but many people they miss to look at the olfactory cleft directly, and often it's blocked, or sometimes it's blocked. And although the rest of the nose is open and free, so people have no respiratory issue, but the olfactory cleft still may be blocked. There's one thing, and then of course I look at signs for inflammation in the nasal cavities. In the brain, I look for the olfactory bulb. So whether it's of normal shape, though the shape also seems to be important, whether it's oval or whether it's more like olive shaped or whether it's more like distorted. And so we have some recent evidence showing that actually the shape of the olfactory bulb also has some information. Just basically what we do. In congenital anosmia, that's a different story. We also look at different parts of the brain.
And since you reported that sense of smell or decreasing sense of smell is one of the prior symptoms for future diseases, for example, for Parkinson's disease and others. Do you think there are some tips and tricks when you're looking for MRI that could be prevention, or some parameters that would say to you, okay, you have a higher risk to develop some kind of other diseases? Do you think it's possible to look around the brain and not just focus it in the olfactory bulb? Because this is some key by now. If we are imagining that one, we can just say this patient could live or could be one of those potential Parkinson disease. We can just say this is a precursor of a disease. Do you think that there's kind of further studies that could be done, and what would you propose for the scientific committee to look around now that is the time that everyone is looking into this?
Mm. Yeah, that's also a good question. It's like what's important is for people with suspect to develop Parkinson's disease, these have to be people with idiopathic olfactory loss, or where it's gradual, or where it's unexplained by any other signs. So that's most important. And of those patients, that about, in our experience, like 10%, they develop later Parkinson's disease. So typically, it's kind of difficult to talk to these patients because many of them, they do not come to us with idiopathic olfactory loss with the questions, will I develop Parkinson's disease? And personally, I find it ethically very difficult to come up with the idea that I talk to the patient and say, hey, there's a chance that you will develop Parkinson's disease. Be careful, watch out. And then they have a chance of 1 out of 9, it's still not very low, that they would develop that. So typically, because right now you can't do anything unless you're not able to treat, unless people develop motor symptoms of Parkinson's disease. So it's a difficult issue in some ways. So no, currently we handle it like this. So when patients come to us and they mention it with there a certain chance that I will develop Parkinson's disease, of course, we would discuss it very offensively and very openly. But unless the patients themselves mention this to us, I would not talk by myself to a patient with idiopathic olfactory loss about the Parkinson's disease, because this can create so much panic and you can't treat it really. So, and also it's difficult to prove. So you're asking for a concrete diagnostic sign. That's more or less, it's very difficult to diagnose early. There are, of course, sleep disorders that you can have. You can have like depression, these unspecific pain syndromes that are may, when you put it all together, it may allow you an earlier diagnosis of Parkinson's disease, but it is very difficult. And looking at MR scans, to my knowledge, a routine MR scan is not very informative about that. So you need to be very specific. You need to have an experimental scan of the brain, and best would be a DAT scan where you look at dopaminergic transporters to see what's happening there.
Great. So there's so many questions. You might not aware, but we are not using Zoom to enter all the people around, but because we just providing a social streaming all around our platform. So I'm managing all the questions, but due to lack of time, I have just to quit this by now with the last question from us. And my question is this: I would like to raise some concern in the fact that some studies has been carried on in the early period of the pandemic, and I don't want to say that those were carried on good in a good way or in a bad way, but do you think that could be possible to address um, a sniffing test, or an objective test, because many questions should be asked from those patients, and during the pandemic or the infection period, you cannot go there and say, okay, you have to do an objective test. I've managed this because it was so hard for me to go there. Fortunately, we had some OPSI tests to provide to this patient, because otherwise, to the sniffing test, you have just to put it in a trash, and we know that those kits are very expensive. So, what would you suggest to those scientists that would like to go and ask and do some research, objective research? What would you say to them? What would you suggest to them to objectively study those patients?
Yeah, that's also a good question. It's like currently when you have patients, acute patients in front of you, suspect of corona,
Mhm.
then of course you need to ask them. They have to rate their effective function. That's very helpful. But at the same time, I would always try to measure it. And the simplest way to measure it is an odor identification test. And there's like, ideally it's the upset. So because it's disposable, or you could also create a very simple olfactory test by yourself, but then it's not validated. It's a little bit more difficult. So currently, I think The opposite would be in the acute phase, when people walk in the door with signs of COVID, then the opposite would be the olfactory test of choice. Later
Oh,
on, you can do different things. So I think later on, when people are outside of the acute phase, one can also do odor thresholds and, for instance, use the sniff and sticks. Then they're also very helpful.
I was exactly getting to this point because this is available easily, the opposite one, and you can put it in the trash, otherwise you cannot use it for somebody else. So I think that what we should address by now is to um, look out for those patients in an acute phase and then watch out them once the virus is being cleared away, to assess and to see the differences, to have more information regarding those patients. I think that the mandatory now is to follow up those patients and not leaving in this. And I would love to suggest everyone to do it, because now we have some. I'm sorry for this bad video. So we have. I had this problem after 4 months. This parosmia came out 4 months after the recovery. So this is the time to let everyone knows that people could be, generating other symptoms during this time. So if anyone would love to reach to you personally or can follow you and ask you question, is there any chance for them to visit your clinic or follow your work? They could just go in the PubMed, or there any chance to get into you for questions?
Sure. So everybody could visit our clinic. So they're free to come here and make an appointment. It's one thing. The other thing is you can also send me an email. Of course, by email, it's kind of difficult to counsel people personally. So we try to stay away from that. Also, I would love for diagnostics. I guess like every medical doctor, you would like to see a patient in front of you. So we're happy to do that, but we're also happy to talk about all kinds of questions about olfactory function. I guess so. So it's that's. I think the smell community is very open to all kind of questions, and so
I've been lucky that I found the right person, and I was really glad when I got the connection. There's Dina over here, and was so glad to reach with them, to Michael, all of those people that helped me a lot, involved me in these studies. We are currently doing a lot of stuff worldwide. I was glad from yours about the parosmic questionnaires. We are trying to provide as much as possible, and I really hope that the community and the ENT would by now looking forward to have more specific interest in the smell and taste disorder, and not just only on surgery. I was one of those surgery addicted, but by now I think that I will probably switch a little bit of my research, and I will probably be more focused on others, and even on, since my association, our association is called Naso Sano, means healthy nose. We will probably in the future be one of those one that will study the mitochondria and the respiration of the mitochondria inside of ourselves.
sounds great to
Thank,
me. Well,
thank you so much, Professor Hummel, for being with us today. I hope to get back to you in the near future. For all our colleagues and or our attendees, thank you so much for providing your attention to our community and to our grounders. Thank you so much and have a nice day.
thank you for the invitation.
My pleasure.